Hello, I'm Norbert Gleicher, MD, Medical Director and Chief Scientist here at the Center for Human Reproduction. And we are having a podcast today in which I will ask Cari Nicholas, our supervisor in the embryology laboratory, some, I think, interesting questions. And if you have some additional questions, you can always reach us here at the Center for Human Reproduction. We actually enjoy answering them, even if it's one-on-one. So, Cari, welcome. We are talking every day, but we are now doing this, obviously, for a much larger public. And so let's get started with you maybe talking us through what happens in the laboratory. I mean, through the little hand-through area in the embryology retrieval room. The moment eggs are retrieved and handed over to you guys in the embryology laboratory.
Thank you, Dr. Gleicher. So once we receive the eggs after retrieval, there are a couple of things that we do. We receive tubes. They are filled with follicular fluid and hopefully an egg. And that tube is emptied into a Petri dish where we start the search for the egg. Once we find an egg, the egg is then rinsed. We let the physician know that we have an egg, and then we place it into a culture dish that will then go back into the incubator.
Tell me how long it takes to find an egg. There's a reason for this question.
Normally it's seconds.
Okay.
Normally it's seconds.
So the reason for this question is that, I'm an old timer and I started one of the first IVF clinics in the country in 1981, when you couldn't hire people like you to run embryology laboratories. And you know how long it took us to find our first egg?
How long?
3 hours.
Wow.
The embryologist was a PhD who was running my research laboratory at the time. So he knew as much about embryology as I did at that point. Yeah, 3 hours. We found it and it's still fertilized. Anyway, let's go on. We have obviously made a lot of progress since then. Tell our audience how you then determine what the quality of the egg is, what the maturity of that egg is, and how you get it ready for fertilization.
So, as I mentioned, it goes into the incubator for culture. It cultures for a couple hours, then we remove it, and then we do what's called stripping. So the egg itself has a lot of cells around it. We call them cumulus cells. And we have to remove them in order to see if the egg is mature. And we do that for ICSI, which is intracytoplasmic insemination. So we do that for ICSI, but when we're doing insemination or conventional IVF, we don't remove those cumulus cells. So let's talk about ICSI first. So when we're doing the stripping, we're using that mechanically and chemically. So chemically, we use a very gentle enzyme to remove those cumulus cells or the cells from the egg. And then we're able to see whether the egg is mature. So we're looking for a couple of things. So if an egg is mature, we will see what is called a polar body. If the egg isn't mature, it could be immature, and there are two stages. So there's a GV, which is a germinal vesicle, and you'll see a nucleus in the center, or sometimes peripherally off to the side, and you'll see a nucleoli. So basically, you'll see it's kind of like a bullseye. Will be a circle with a dot in the middle. That will be a germinal vesicle. Or you'll see an egg that doesn't have a germinal vesicle or a polar body, and that is an M1. So it's an intermediate stage. So the M2, the one with the polar body, that is mature, and those are the ones that are ready to be inseminated for fertilization.
Okay. And which kind of takes me to the next question. that we often hear from patients or other members of the broader public. When do we do ICSI, and when do we just let the egg and sperm do the job on their own? I mean, you and I know that at CHR, because of our patient population, most of our patients need ICSI and have ICSI. But let's assume in a general IVF clinic where patients have a much younger and more usual patient population, which cycles should get ICSI and which cycles can just have normal spontaneous fertilization.
So generally, ICSI is used for when you have male infertility, essentially when you have low concentration of sperm, motility, and low morphology. So an abnormal semen analysis is when you would use ICSI. If the parameters are normal for the male, you tend to move along doing conventional IVF, generally in other clinics.
Okay. Uh, we have an additional reason why we do ICSI, and that is that it gives us a good excuse to look at the egg after 24 hours and see if we have fertilization, which again, obviously in our patient population is very important to find out. There's something else that a lot of patients ask about all the time because it kind of runs in parallel to the ICSI term, and that is AZH, assisted zona hatching. What's kind of the ideas about assisted zona hatching? That has also become somewhat of a controversial issue. We used to do it all routinely on almost everybody. Some people are questioning this now. If there are patients to get assisted zona hatching, who should those patients be?
So essentially, generally, the patients who get assisted zona hatching would be the patients who eggs were frozen and we created embryos. They obviously need ICSI because they have the hardening of the zona. And it's the same reason why they need assisted hatching because you have the hardening of the zona. It's the freeze and thaw method changes the composition of the proteins in the zona pellucida. And that causes a hardening, and thus you need to do ICSI and assisted hatching. So we do that at the stage of whether we're doing day 3 transfers or blastocyst transfers.
Stepping back, how do you know that an egg has fertilized? When and how?
So once we do the insemination, the following morning we do fertilization checks first thing because fertilization signs of fertilization actually disappear between 16 to 18 hours. So we want to be able to catch that window. And there are two signs we look
This
for
is why we
fertilization.
need to look. Yes.
Yes. Two signs of fertilization. Really, the main sign of fertilization are two pronucleases. We also use two polar bodies, but two pronucleases is really what designates fertilization in the egg.
And that's a really very obvious sign. In other words, it is relatively easy to know whether an egg has fertilized or not, which many patients are very anxious about finding out on the first day after their retrieval. And so this is an important point, I think, to notify. Now, since we're talking about observing eggs and embryos, maybe I ask you also about some of those closed incubation systems that a lot of IVF clinics have started using. When they first came on the market a good number of years ago, we kind of tested them out again in our very unusual patient population, and we not only found that they didn't help, but in certain patients, they actually seem to harm our outcomes. So we are not using them. But the general public usually will confront that because so many IVF clinics now have them. What would you tell those people about what they should ask about in those early days after fertilization? What should they look for in an embryo to happen or not to happen?
So I think there's a couple of things. So we're talking about like using time lapse, for instance. So those clinics that are doing time lapse, they tend to culture after fertilization up until day 5 or day 6. They do undisturbed, then they do not.
Yeah, so just
They do
for
not check.
explanation, excuse me for interrupting, but just
Sure.
for explanation, time lapse means closed incubation system, a camera on top that kind of takes pictures every few minutes, and where you can basically on a screen see what is happening to your embryos over the next few days, just as an explanation. So many clinics are using that. We are using it really only for research projects. But what are you looking for?
So essentially, we're looking for the egg over a period of time to do division, cell division. So you want the egg to double its number of cells every 24 hours. So at time of fertilization, you have a fertilized egg or zygote. 24 hours after that, you expect to have a 2-cell embryo. Another 24 hours after that, you expect to have 4-cell, then 4 turn into 8 on day 3. So basically, what we look for in the embryos when we pull them out of the incubator and grade them on day 3, we're looking to see where they are in development. Are they within the time period that they should be for day 3, 6 to 8 cells, evenness of the cells, and also whether there's fragmentation, or are they going a little bit slower? Are they going a little bit faster? And this gives us indications when we get to a point of deciding what we're going to transfer. Not just looking at the egg, but the development at day 3 to determine how they're doing in order to basically do a selection, using all of the different morphological aspects from the egg to fertilization to the day 3 development to make an informed decision on how to proceed with a transfer for a patient.
And that is a crucially important point. Day 3, uh, because we here, once again, because of our unique patient population, we very frequently decide already on day 3 to transfer those embryos for reasons which are not always very clear to me, but that is a separate issue here. Most of our colleagues have made it a routine to culture embryos to what is called blastocyst stage, which is usually reached on day 5 or 6. We frankly don't understand why that is being done as a routine, but maybe what it is. Day 3 is important, as you said, because we look both at the egg and the embryo. And we do that because there are good-looking eggs that become lousy-looking embryos on day 3, and there are not so good-looking eggs that surprise us sometimes by day 3. I want to comment about this because so many other IVF clinics really hardly ever look at the egg itself.
Well, I think one of the things we look at is the granulation of the cytoplasm. We look at the side of the ventricular space, which is ventral space, which is what we call the PVS. And we make determinations of the thickness of the zona, the clarity, not just granulation, but whether or not the cytoplasm is clear and you could actually see through it. So we make inferences on the egg and make notes of that. And that helps us to tend to predict for the patient, especially if they had multiple cycles, what that will look like for the day 3 embryo. And then sometimes, like you said, it's surprising. We have beautiful eggs, and then we have very poor quality embryos. Um, and obviously, there are different things that are happening, switching from being able to switch from the genome of the egg to the genome of the embryo. Sometimes you have beautiful embryos, you have beautiful eggs that fertilize very well, but never cleave. So again, there are different developmental stages and periods that the egg and the embryo has to go through to basically be a checkpoint to get to the other stage. And some of them do not have the capacity to do that, and some do. And sometimes that is outside of morphology or anything that we could see with our naked eye under the microscope.
Yeah. And um, most embryos that arrest, meaning that stop growing, or maybe we can call it die, do so between day 3 and day 5. Isn't that true?
Yes. The third mitotic division or development during blastulation. So those are the periods where they tend to undergo arrest. Yes.
Yeah. And until, what was it, maybe 10 years ago, maybe a little more than that, the whole world used to transfer embryos on day 3. And then one paper came out from colleagues in Colorado making the claim that culturing embryos to day 5 improves pregnancy and live birth rates. And it took a few years, but that single paper kind of caused a revolution in our field, and suddenly most IVF clinics are culturing routinely all of their embryos to day 5. We don't do that here at the Center for Human Reproduction, and we don't do that because, again, we're serving a very special patient population who usually has failed already many cycles before they come to us, and who not only is older, but therefore also produces much fewer eggs and fewer embryos, and therefore every embryo is worth gold. Moreover, a recent data suggests that when you really look at cumulative pregnancy chances from all the eggs and embryos that one IVF cycle gives you, the claim that you get better pregnancy and live birth rates from routine blastocyst stage culture is really not correct. The cumulative rates are actually pretty simple for day 3 as well as day 5, 6, 7 blastocyst stage cultures. So why really culture everybody to blastocyst stage? And I'm not asking here even about the additional costs that this produces, but why would we do that? Any ideas why our colleagues are so enamored with blastocyst stage culture for everybody?
I think there are two things happening. One, I think it's a matter of embryo selection. If a patient has a lot of embryos, it is fine to culture them out. If a patient has 12 embryos, it's fine to culture them out. They will lose some. They'll have a few blastocysts, and so you could have single embryo transfers. Instead of having, 9 single embryo transfers, you maybe have 3 single embryo transfers because you're picking the best. Another aspect of the embryo selection is not just about morphology, but about genetic testing. So when pre-implantation genetic tests came around, growing to blast initially it was on day 3, but then it proceeded to be done on blastocysts, and so you have to grow to blastocysts in order to do the PGT testing. And so majority of clinics are doing PGT testing, so they have to go the blastocysts out. And they're using that as a selection method, whether they're using it for morphology or for genetic purposes. That's what most clinics are using it for, to reduce the number of transfers. That is the consensus in the field currently.
Yeah, very good explanation, and I obviously completely agree with that. But that's also one of the reasons why we here at the CHR are not big fans of chromosomal testing of embryos, and in general consider that to be a pretty lousy test. And that is just another reason why we actually do not culture all of our embryos to blastocyst stage and often do transfer on day 3. But since we're talking about that, there's also kind of a third option there, and we do that quite often here at the Center for Human Reproduction, and it's kind of a little bit of a paradox. We transfer on day 3. We usually freeze our good-looking extra embryos on day 3, but then we do something that seems kind of crazy. We continue culturing the not so good looking embryos.
Yeah.
And can you explain to our audience why we do that?
So the not so good looking embryos that have high fragmentation or unevenness of the cells, a lot of the times they have a lower probability of surviving the freeze toss. They also have a higher probability of embryonic arrest. So in order to be able to see if these embryos have the capacity to continue to develop and grow, we will culture them to see if they can actually go beyond that stage of cleavage. So there's a lot of things that that embryo has to go through in order to become a blastocyst. Like it has to go from, cleavage stage embryo into what we call a morula. And during that stage, they develop polarity. And those cells have to then be designated to different parts of the embryo. And that in itself is really a big checkpoint for the embryo to go through to really continue to develop. If it can't develop that polarity to decide which one is going to be the placenta or the trophectoderma, which one is going to be the inner cell mass of the baby, if it can't get to that point, then it's not going to continue to develop and it will eventually arrest in that morular cleavage stage. So we continue to grow them to see if they could get to that point. And if they become good quality or fair quality embryos, then we freeze them because at that point in time, we know that they have a high probability of surviving and developing and also high probability of surviving after the thaw.
Wonderful explanation. Again, wonderful explanation and demonstrating how seriously we take every egg and embryo here at the Center for Human Reproduction. We're truly fighting for every egg and embryo, which has since the beginning been a slogan. Which brings me back to the egg, because most IVF clinics, once an egg is found to be most immature at what you noted before to be the GV stage, the germinal vesicle stage, most IVF clinics still throw out those eggs. Once again, this is not what we do, right?
No, no, that is not what we do. Here at CHR, we do rescue IVM or rescue in vitro maturation. So essentially, what we're doing is once we've done the stripping, removing the cumulus cells, we see whether they're mature, they're immature or immature. And one of the things that I noted to you is that we do a culture. So whether they're mature or immature, we culture them. But we do separate them if they're immature. If they're immature, they go into our special IVM media and then they're cultured for 24 hours. Um, a lot of clinics that don't do IVM, it's because one, they don't have an IVM system set up. So you have to get to a point where you want to do IVM and you're able to do IVM. So you have to go through all the checks and balances just as you would do any other technique in the lab. And so maybe they don't have that in place in order for them to do IVM. But I think that IVM is something that is becoming more frequent and more people are now in tune with the fact that you can use these oocytes, and maybe too some of these bigger clinics they have younger patients who have 25 eggs, and so they might not be as a big incentive for them to do IVM for their patients as it is for us. For our patients who have 1 or 2 eggs, if it's immature, then we discard that, then the patient has no chance. So we give them a chance, we give them an opportunity to be able to mature these eggs and give them an opportunity to have a chance to inseminate, fertilize, and hopefully have a transfer.
Again, coming back to fighting really for every egg and embryo, which is so important in the kind of patient population that we are serving here. And it's really an absolute commitment at our place. Okay, let's go to the next point. Um, Tell me what is in principle different between a young patient and an older patient. And maybe you can sneak into your answer here. The paper in which you were the first author, I think a year and a half ago or so, where we broke another dogma in IVF and showed that actually the maturity grades of M2, M1, and GV, which we all used to believe maintain the relevance of what they mean, meaning that we want as many M2s because they give us the highest percentage of good embryos, and we want as few GVs because they hardly ever give us a good embryo, which is true in young people. But then we discovered something very unexpected.
So, what Dr. Gleicher is alluding to is that, so I think in theory, we we believe we believed that all immature eggs and mature eggs were equal among young and old patients, and that they behave exactly the same. I think one of the things that we showed in the paper that was published like a year and a half ago was that that may not be the case, especially for the older patients. And it could be for a couple of reasons that we alluded to in the paper. So, in the older patients, we talk about how they have very high FSH levels and they have a lower ovarian reserve. Obviously, the AMH levels are much lower. And so the microenvironment that those eggs are in for that long period of time could affect the maturity of the egg, but also to the quality of the egg. So both an M2 in a 30-year-old is not the same kind of M2 in a 50-year-old or 45-year-old. And so when we're doing these inseminations and we're getting, poor quality embryos, we're seeing, okay, it was mature. Yes, there's some characteristics of the eggs that will suggest poor quality, but they're all M2s, so they should behave the same, but they do not. What we noticed that for the immature eggs, the GV specifically for the older patients, is that they do mature. And when they do mature, they actually create better embryos for the older patients than the M2s do for the older patients. So essentially, the M2s seem to be like they're overly matured, and the GVs, instead of behaving like true GVs, they might be a little bit further along, but they have a better quality when it comes to creating the embryos for these older patients. So it might seem strange initially, but if you think about it, the science of it all, it makes complete sense.
And science always makes complete sense. It sometimes only takes us very long to understand it. And I think this is a good example because I bet if you go out and ask 100 embryologists out there, 95 of them will probably still believe that an M2 is an M2 and a GV is a GV, whatever the age of the patient is. And that is obviously not the case. All right, let's go on and talk a little bit about how do you look in detail and how you judge in detail an embryo. You told us already about how we look at the eggs morphologically. Uh, Tell us a little bit more how you look at the day 3 embryo, or maybe even more importantly, about how you look at the blastocyst stage embryo.
So I'll start with the cleavage stage embryos. As I mentioned before, on day 3, you should have 6 to 8 cells. So one of the things we look at is the number of cells. Also, because the cells are doubling, are dividing every 24 hours, you expect that they should be relatively the same size and you should have even numbers. So you're looking at number of cells, evenness, and also fragmentation. And basically, fragmentations are bits and pieces of cytoplasm encirculated with a plasma membrane that doesn't necessarily have nuclear or a nucleus or genetic data. So it's basically just fragments that come off of the cells that are not useful to the cell. And so we determine the grades based on looking at those 3 parameters: fragmentation, evenness of the cells, and number of cells. And that gives us the morphology of the embryos. I'm not going to go into the way we grade in terms of letters and numbers because different places grade differently, but essentially everyone is looking
And
at the same thing.
and you are the most critical grader of them all.
I can be. I can be. So
Yes.
day 3, everyone is looking at number of cells, evenness of the cells, and fragmentation. So for blastocysts, which would be day 5 or day 6, we look at something that's a little bit different. We're not counting cells anymore. We're looking at the expansion of it. How big is it? How much fluid is filled in it? Um, and then the expansion, the second thing we look at is the number of cells and the position of the cells within the inner cell mass, which makes the baby, or the trophectoderm, which creates the placenta. So we're looking at the number of cells there, not necessarily counting, but kind of like the distribution of the cells. So are there a lot of cells? Are they small? Are they big? Are they compact? Are they spread out? Are there scarcely any cells? And that's what we're looking at um, for the blastocysts. We also look at the thickness of the membrane of the zona pellucida, sorry, and that tells us basically how far along it is. So the 3s are much thicker, the 4s are thinner, the 5 means that they're hatched, so part of the blastocyst is outside, and a 6 would mean that they're entirely outside of the zona pellucida, they're free to then implant into the uterus.
Okay. And some embryos reach blastocyst stage on day 5, and they're the best. And some embryos take up to day 7 after fertilization to get to blastocyst stage. And in terms of pregnancy chances, they are obviously the least likely to get pregnant. Is there something else besides the day where they reach blastocyst stage that may differentiate between a day 5 and a day 7? Or do they look the same? That's basically what
They can, a day 5 and a day 7 can look the same. They can. It just depends on when that embryo gets there. So technically, the longer it takes to get there, the consensus is that the less likely it will implant.
Yeah,
The lower the chances because it takes a longer time to get to that
yeah,
point of development.
yeah. I mean, clearly day 5 embryos are the preferred embryos. Another big issue that differentiates what is happening at the Center for Human Reproduction and pretty much anywhere else in embryology laboratories is the timing of when we do our egg retrievals. Now, we, like the rest of the world, for several decades, to be specific, until probably roughly 10 years ago, 10, 12 years ago, we too routinely triggered our patients when the lead follicle, the biggest follicle in their two ovaries, you reached the 18 to 23 millimeters in most cases. Sometimes we even went longer. But that's not what we are doing any longer, right?
No.
And we have a lot of visitors from all over the world who come to visit us and are frequently quite surprised how different we manage our, or many of our patients from what is considered standard IVF care. But the thing that really surprises them most and even drives them a little crazy in the beginning when they come to visit is that we are sometimes retrieving eggs from follicles as small as 6 millimeters or 8 millimeters or 10 millimeters.
Mm-hmm.
And tell our audience what that means, because all of those colleagues who come to visit us immediately ask, aren't you getting all those immature eggs, right? But tell our audience what is happening to follicles as women are getting older.
So one of the things, like you said, the dogma is that you're triggered at 20, 21, and that has always been the dogma. But for our patient population, you trigger at that size. One, some of them don't make it to that size and they ovulate.
Yeah.
Two, if they do make it to that size, we get eggs that are atretic. We get eggs that are degenerated.
What we
Um,
call hard boiled instead of soft boiled.
yes, we get
Yes.
overly mature eggs that don't don't fertilize. If they do fertilize, they don't cleave, and so we retrieve earlier at smaller follicle sizes, and we actually get mature eggs in these smaller follicle sizes, and they do better than if we retrieve later. And the immatures do better because we culture them in vitro, and they do better as well. So the microenvironment that they're in is very different to the younger patients. And so it's also true not just for the older patients, but the younger patients who have high FSH or and low AMH, and they have diminished ovarian reserve. It's also true for those patients because their environment is somewhat similar, not identical, but somewhat similar in that same regards. And
Yeah.
so,
That's why we
smaller,
call that's why we call them to have premature ovarian aging.
exactly.
Yeah.
And so, it's not just chronological age, it's really ovarian age or reproductive age that is important for doing those early retrievals and getting us better quality embryos, better quality eggs, better quality embryos, and more chances for transfer for these patients.
Yeah. Very, very important issue. Uh, and this kind of work led us very recently to recognize that we're breaking another dogma, which is that you expect the most mature egg always in the biggest follicle. And while that as a trend is obviously correct, especially in older women, you can sometimes find the most mature egg in a much smaller follicle, right?
That is true as well.
And we sometimes go through special exercises where we retrieve on purpose very slowly. And I ask, Cari, how does this egg look, right? It's simply
Yes.
based on how the egg looks on ultrasound or how the follicle looks on ultrasound.
Yeah.
Okay, we are kind of running out of time, so let me come to my concluding questions. What do you wish more patients understood about what is going on in a good embryology laboratory?
I think they should understand that what we do is very meticulous. It's very technical, and it is something that we pride ourselves in to be able to help the patients as much as we can. We do our very best technically, and being able to advise the patients as well about what's going on in the lab and how to do it, how we're doing it, and being able to come to a point of giving them the results and them being able to understand it. I think that sometimes we're just, it's kind of like we're behind a wall and no one thinks about exactly what we're doing. But we do put a lot into making sure that your eggs and embryos are taken care of and that everything is done efficiently and as close to physiologically possible as we can to be able to get you to a point of having a pregnancy and a live birth.
And I have to second that and have to say we couldn't do what we are doing on the clinical side without you guys. And I also have to say that's exactly why so many other IVF clinics are always trying to hire our embryologists away. Okay. Are there common myths or misconceptions about embryology that you would like to clear up here?
There are a couple of things that I could think of. I think on the retrieval side, I think that, you know, we give the patients a number of follicles. So we say, oh, you have 12 follicles. And the patient expects that they will retrieve 3 eggs. I want to make sure that everyone knows not every follicle has an egg. And so you may not have the same amount of eggs that you do follicles. Also, too, that if you retrieve 5 eggs and we inseminate 5 eggs, not all will fertilize. There are times when we have 100% fertilization, but that is not always the case. And not every fertilized egg develops into an embryo, and not every embryo develops into a blastocyst, and not every blastocyst implants, and not every pregnancy becomes a live baby. So I want everyone to know that within every step, there's a percentage or a rate at which these things happen per patient, and it's individualized. It's not a universal thing where if you're 30 to 35, this happens, but it's really an individualized thing. Here at CHR, we believe in individualization, treatments for each patient, and we treat each patient based on their individual diagnosis. And so different things will apply to each patient based on your diagnosis and your treatment here at CHR.
Great answer, which is also a perfect lead in to my last question. And that is that in most IVF clinics, if you have only 1 or 2 follicles, they will cancel the cycle. In our patient population, if we did that, we probably wouldn't have very many IVF cycles, right?
Not at all.
Uh, because going for a single follicle or 2 and 3 is already a wonderful situation for us, is our really daily routine. How does that change how you manage your embryology laboratory?
So for us, every egg, regardless of the number of follicles, the number of eggs, every egg is important. Every single one. None of them have less importance or more importance than the other. And so, if a patient has 1 egg, we will look for the best sperm in millions of sperm in order to inseminate that egg, in order to get the best embryo possible for the patient. So, every egg counts. Even if it's just one, that patient may not have another chance. It may be their only chance, and it may be their only follicle. And so we can't just say no because you have one follicle. We have to take our time, do the retrieval, and give as much as we can to be able to maximize the cycle for the patient. 1, 2, 3, 10 eggs, regardless.
And we are working long enough together to have seen a good number of patients with 1 egg, 1 embryo, 1 baby.
Yeah.
And we have even seen not too long ago a case with 1 egg, 1 embryo, and 2 babies, right?
Yes.
So one never knows. And those are obviously the most happy circumstances.
Of course.
But let's close with those cases where we have to tell a patient, sorry, but we didn't get an egg in this cycle. Tell our listeners, which these moments are probably the hardest for you, they are the hardest for us. But tell our listeners how we deal with that in the framework of being a last resort IVF clinic like we are, where patients usually show up after they have done 5, 10, 15 cycles elsewhere. How do we deal? How do you, on the embryology side, which at least here at CHR is so closely involved with patients, how do you deal with patients in those situations?
So I think ideally, what we do is we're very sympathetic to them. We understand, we go through the process of when they're doing consultations, we review these patients prior to their retrieval. So we know what we're expecting. We know what a good outcome could be for them. We know what a bad outcome could be for them. And so we're reviewing, we're hoping, okay, they had 3 follicles before, maybe they'll have 3 again, maybe they'll have 1, maybe they'll have none. If a patient has 1 follicle, we do the retrieval and we don't retrieve an egg. We have a conversation with the patient. And a lot of the times I think the patient just wants to understand why. Why is this happening? Why is this happening? Like before a cycle, I've had 3 follicles or I've had 2 follicles and I've had eggs, but why is this happening to me at this point in time? And I think being able to explain the science to them in regards to how the ovary works and how recruitment of eggs work. Not every cycle is the same, even in IVF. Not recruitment of every the antral follicles are not the same, even if you have back-to-back cycles. And so I think for me, I like to be able to explain to them the science, and I think it gives them comfort to actually know what's going on inside of their body rather than me just saying, well, you don't have an egg.
Yeah.
Being able to explain to them and be empathetic and tell them, this is what happens in the ovary. This what can happen. It may not happen every cycle, but this is just this could be a bad cycle, or it could be something that's going to continue to happen as you go towards menopause. So being able to explain to them what is happening, how it happens, and give them some hope for the future, but also be realistic in what can happen. And I think that really helps them to have that personalized, professional opinion because it's for them personally, but it comes from someone who's talking about the science behind of it and understands not only the science, but the emotional and physical and financial toll that they go through, that we go through with them together.
Very good, very good. And I also want to point out again, trying to reemphasize that we couldn't do what we are doing on the clinical side without you in the embryology lab. We have a weekly conference where we review every cycle that has not led to a pregnancy. And it involves not only embryology and us doctors, but even our clinical staff, our clinical coordinators. And the reason is exactly what you were just outlining in how you explain things to patients. We sometimes are also surprised by our outcomes, both in the good and in the bad. And we are trying to learn. And I think if we have learned one thing in all those many years is that we learn most from looking at those cycles, from what we are seeing in our patients' cycles happening and discovering patterns and reaching the right conclusions from what we see. Cari, I thank you very much for this conversation. I learned again something, and I hope we do this for many more years together. Thanks very much.
Thank you for having me.